So you are shown a picture here, and the question is, what is the procedure shown in this model? Are you all able to see the picture clearly?
Yes, sir.
Yes, sir.
Yeah. What is being shown in this model? Patient is lying in the lateral position. There are multiple folds made.
Sir, VAT, sir.
Yeah, video
Video assisted thoracoscopic surgery, sir.
Very good. Right. What types of surgeries can be done by video assisted thoracoscopy?
Sir, decortication.
Cortication, okay. Can divide lung surgeries, cardiac surgeries,
Pneumonectomy, sir.
pneumonectomies. Pneumonectomy is not very commonly done by what?
Okay, sir.
So you can lung, heart, and esophagus surgeries. You can add like that simply. Okay, very easy to remember. Lung, you can even CABG, minimally invasive, they do by this. Okay, so lung, heart, and esophagus surgeries are done by what? What anesthetic technique is used if you are asked to give anesthesia?
One lung ventilation, sir.
One lung ventilation. What is the difference between open thoracotomy, one lung ventilation, and this ventilation? For general anesthesia with the deflation of the lung, that is the question. So how that deflation is achieved? Of course, you answered that. That is by using a double lumen tube or a single lumen tube with a bronchial blocker. So that is basically one lung anesthesia. But what is how do the corrective steps to prevent hypoxia during one lung ventilation differ during VATS from open thoracotomy procedures? You can do one lung ventilation both during open thoracotomy as well as during what? So the steps to prevent hypoxia, what you commonly follow for one open thoracotomy, can it be followed for VAT also, or there is a difference? What are the things that you do for one lung ventilation? Prevent the hypoxia during one lung ventilation. What are the steps you follow?
So recruitment manual to the deflated lung, sir. Intermittent recruitment manual.
Okay. There
Selective
are 7
partial ventilation. Yes, sir.
First of all, higher percentage of FiO2. That is the first and foremost, isn't it? We don't give the same 33% for as you do for other anesthesia. You always try to give at least minimum 50% and go on increasing it. Even sometimes you may be giving 100%. But if you are giving 100%, how will you maintain anesthesia?
TIVA, sir.
TIVA, yes, that is the answer. You have to maintain unconsciousness with TIVA. Then only you can give 100% oxygen without nitrous oxide or air or any other volatile anesthetic agent. So that is higher FiO2 is the first thing to prevent hypoxemia. Then what is the second important thing? There are 5-6 things which you have to remember quickly for one lung ventilation to prevent hypoxemia. There are 6-7 things which you have to quickly remember. One is first higher FiO2. Second is CPAP to the non-ventilated lung, PEEP to the ventilated lung. Okay, you must give higher PEEP to the ventilated lung, and the deflated lung you should give CPAP. Then you must try to increase the FiO2 if required even to 100%. And then once the thoracotomy is done, then you can clamp the pulmonary vessel of that side which is not ventilated, because that is the one which is going to cause or bring the desaturated or deoxygenated blood to the main circulation. And if nothing is working, then you have to go for double lung ventilation. Okay, these are all the steps. But is there any difference in these steps between open thoracotomy, one lung ventilation to VAT? That is the question that is asked. The small differences are, unlike open thoracotomy, you cannot give CPAP to the non-dependent lung here because this is a minimally invasive. They want the lung to be fully deflated. So unlike a open thoracotomy where you can give CPAP to the non-dependent or the collapsed lung, it cannot be applied to VAT, which that will hinder the view of the surgeon. So surgeons won't like you to ventilate that or give CPAP to the collapsed or non-dependent lung. And you cannot use 100% oxygen for long inpatients, especially of those who are treated with bleomycin, may cause oxygen toxicity. And the third point, the last point, where you clamp the pulmonary artery is not done if pneumonectomy is not planned. So these are the three small differences between open thoracotomy, one lung ventilation, and video assisted thoracoscopy. What are the complications of VAT surgery?
Pneumothorax, sir.
Pneumothorax.
Air embolism.
Air embolism, very good. Okay. For what do you use air or you use carbon dioxide? It's something like laparoscopy in the chest.
Yes,
So
sir.
you don't use air to produce that. Here it is pneumothorax. You already told that. Okay. So dysrhythmias like atrial fibrillation and supraventricular tachycardia, bleeding, air leak, infection, respiratory failure if there is a pre-existing pulmonary dysfunction. So these are all the complications. You don't produce. We are producing pneumothorax artificially. Carboperitoneum, we inflate into the lung carbon dioxide. Okay. So the dysrhythmias is the most important thing. Then there can be bleeding, there can be air leak, and infection, respiratory failure. What is being done here?
Sir, NAS endoscopy, dice, sir.
Dye. It's the dye or
This.
you are talking about this as a dye?
Yes.
Because it is
Dice.
colored. This is not a dye. Why do you want to use a dye with a nasal endoscope? This is
Dye,
local
this, sir.
anesthetic agent. Okay, so spray as you go technique. So local anesthetic syringe is fixed there. So it is a awake fiber optic nasal intubation or endoscopy under topical anesthesia. Okay, so that is the answer for this. The awake fiber optic examination by the nasal route. You can see the endoscope going through into the nostrils. Okay, so that is the procedure. Mention a few indications for fiber optic intubation.
Difficult airway.
Yeah, anticipated difficult airway where you cannot do conventional laryngoscopy. What are the conditions where you anticipate difficult airway and plan for awake fiber optic intubation? Commonly given in the examination. There are some clinical conditions. You have to mention the names of few clinical conditions which require only fiber optic.
Trismus, sir.
Trismus, like
Temporomandibular joint ankylosis.
Joint
mouth
ankylosis.
opening restricted. Okay. Then can you do it in Burns contracture neck with a fist flexion where you cannot position the head? Is it not a very common indication? Burns contracture neck. We have discussed about burns, isn't it? So anticipated difficult airway like neck contracture, morbid obesity, TM joint ankylosis, cancer cheek or tongue, or C-spine injury. There are 5 conditions which you have to remember. Burns contracture neck, morbid obesity with the anticipated difficult airway, TM joint ankylosis, CA cheek or tongue where you cannot have adequate space to introduce your normal laryngoscope, or C-spine injury where you cannot position the head and neck for normal intubation. Okay, please remember all these conditions. What are the contraindications for doing fiber optic intubation? Last class itself, I told you, you have only 4 minutes for each question. So the subdivisions plus uncooperative patient, very good. Okay. Will you to say that as the first indication? Patient refusal or unable to cooperate, bleeding in the upper airway, they have any allergy to local drugs or upper airway tumors. If any of these things are there, then you are not supposed to, or you will not be able to do fiber optic intubation. What is the sensory nerve supply to the nose?
Maxillary branch of
Maxillary.
Fifth cranial nerve.
Maxillary branch of trigeminal nerve, sir. Anterior ethmoidal nerve, posterior ethmoidal nerve.
Then, more important than that, nasociliary, nasopalatine, and ethmoidal nerves. 2 nasal. See, nasal nerve supply to nose means there should be the word naso. So you can remember nasociliary, nasopalatine, and ethmoidal nerves because they come from the root at the junction of the nose with the forehead. So remember nasociliary, nasopalatine, and ethmoidal nerves. These are the 3 important. All are branches of trigeminal nerve, first division and second division. Okay. What are the techniques of anesthetizing the nasal cavity?
Smart technique. Spray atomization.
Nasal cavity. I am asking only about the nose, not the entire pharynx, everything. Question is about what are the techniques of anesthetizing the nasal cavity?
So nasal spraying with oxymetazoline, xylometazoline, vasoconstrictor, topical vasoconstrictor, sir.
That is not the anesthetizing technique. That is only for vasoconstriction. That is one of the preparations to avoid bleeding.
Cotton pledgets, sir.
4%
local anesthetic soaked cotton pledgets.
Or spray or nebulizer. Okay. So 4% xylocaine. That is a very important concentration, you must say. Nowadays we have 10% xylocaine puffs also, sprays also available by Neon. So that is also being used. But when you use 10% xylocaine spray, you have to be very careful because how much is each puff? When you use 10% xylocaine spray for
10 milligrams.
10 milligram per puff. So you have to be very, very watchful about the number of puffs you apply. Whereas 4% xylocaine, it comes only in liquid form. That can be put in a sprayer and then sprayed or nebulized. Then what is Moffat's solution?
Cocaine solution.
Correct. It has got cocaine and another 2 ingredients. All 3 combined together.
Soda bicarb, sir. Soda bicarb.
Soda bicarb, very good. And then what is the vasoconstrictor used there?
Adrenaline.
Epinephrine. Yes. So it is a mixture of adrenaline, sodium bicarbonate, and 10% cocaine. Okay. It was introduced for nasal surgeries by one Dr. Moffat, who was an army ENT surgeon. Okay. So he used this mixture to anesthetize the nose. He used to do septoplasties, rhinoplasties, all these things using this mixture. What is Sego technique?
Spray as you
Spray
go.
as you go.
Spray
technique.
as you go. It's an acronym for spray as you grow or spraying LA through working channel of a fiber optic scope. Okay, very good. What is shown in the transesophageal echo images? These are echo images taken from a transesophageal echocardiography.
Firefly
And
sign.
still,
Firefly sign for air.
firefly sign for
Air.
what?
Enter.
Air entering the
Air
RA.
bubble.
Very good. Venous air embolism entering. See, they have given 4 pictures. RA, RV. You can see small dots coming here. Then the dots are increasing here, and finally you get so many firefly like appearance. Minmini puchi parakara mari. Tamil sonnaka. Sometimes you get lot of insects flying with a tail or light order. So this is called the firefly appearance in the right atrium, which indicates entry of air. So venous air embolism. This is a classical picture which you can easily identify. Okay. So venous air embolism entering right atrium. What monitors help to detect if there is a venous air embolism? What is the monitor you commonly
Yes.
use if you are going to
It
do
is
a
CO2, sir. Capnography.
T is
capnography?
T
Is
is
that the first one?
Doppler.
T is
Doppler.
Doppler.
Hmm.
T.
Okay. Precordial Doppler, transesophageal echocardiography, mass spectrometry for end-tidal nitrogen, PtCO2, SpO2, CVP, PAP, esophageal stethoscope. All this can detect because you will get a sudden drop in EtCO2, sudden drop in SpO2, there will be increase in CVP, pulmonary arterial pressure will collapse or drop, and the esophageal stethoscope also can produce, you can hear that murmur, churning murmur of the air embolism. How do you treat venous air embolism?
Durance
Especially in
maneuver.
surgery.
Durance maneuver can be done.
Durance
Ask
maneuver.
surgeon to
Stop the surgery. Flood the
stop the
fluid.
surgery.
Yeah, every step you have to say. So notify the surgeon to close any open veins or sinuses. That is the first and foremost thing. Close veins and sinuses or flood them with saline. Increase venous pressure in the head by lowering the head. Supposing if the patient is in the sitting posture, you are doing a posterior cranial fossa and you suspect air embolism, then immediately patient's head should be lowered and in fact it should be made to the Trendelenburg position, head down position, compression of jugular vein, and then discontinuing nitrous oxide if you are using nitrous oxide, support cardiovascular system with IV fluids, inotropes, or aspirate the air through either a CVP or a pulmonary artery catheter if it is already present. These are the various steps in the treatment. What is shown here? This drug has come into market.
Gamma Dex, sir.
Available now in Chennai.
Neuromuscular blockade reversal.
Sugamadex.
Sugamadex, yeah, the name is written here. Commercial name is Bridion, but it is now marketed by another company called Varenium in Chennai. So it's a carton containing 10 vials of 2 ml vials of Sugamadex. So everything is written here. It is 2 ml vial containing 200 milligram. There are total 10 vials. So they expect you to write everything. Just writing Sugamadex is not sufficient. So you must describe the whole picture. What category of drug is this?
Modified gamma cyclodextrin molecule, sir.
What category? What do you use it for?
Reversal
Reversal
of neuromuscular blockade.
belongs to cyclodextrin gamma compound and it is used for reversing the antiprogressive muscle relaxant. What is the mode of action and use of this drug? How does it cause this reversal of acronym block?
Encapsulation of the neuromuscular
Ah.
blockade molecules.
So how is this encapsulation possible? What is the structure of that drug?
Donut,
for the
donut,
encapsulation?
donut shape.
It's a large donut-shaped molecule, and it has got a lipophilic core and a hydrophilic periphery. So the periphery is water absorbable. It is easily water soluble, and the inner core is a lipophilic core. So it encapsulates rocuronium molecules, diffusing out of neuromuscular junction and forms a strong bond. And it is used mainly to reverse the neuromuscular blocking effects of rocuronium in children as well as in adults. Since it has no interaction with acetylcholinesterase, there is no need to give glycopyrrolate or atropine. Like when you use neostigmine, there is no need for any agolytic agent. So these are the points expected. Which other muscle relaxants can be reversed using this drug?
Vecuronium, sir.
Vecuronium and
Pancuronium.
pancuronium, all aminosteroids. Other aminosteroidal agents like vecuronium and pancuronium also can be reversed using this drug. Okay. What is the dose of sugammadex for reversal of these agents? Whether you use rocuronium or pancuronium or vecuronium, what is the dose you have to give for reversing the agents?
So 2, 4, and 16, sir. 2 mg per kg.
Very good. So dose differs based on the intensity of block, administration time, and the age of the patient. Okay, so three factors govern the dosage. One is the how severe or intense the block is. What is the time of administration? Whether you are giving it immediately after giving a non-depolarizing block like rocuronium, or you are giving it after half an hour of the drug administration, or you are giving it during the time when the patient already has started his spontaneous respiration. So that time is very important, and the age of the patient. Based on that, as I think Pratik, you answered that 2, 4, 16.
Yes, sir.
So they remember that those magic numbers 2, 4, and 16. So moderate block, you give 2 mg per kg. Intense block, that is after about 10 or 15 minutes of administration of the drug, and you want to reverse at the time, you have to, even when the spontaneous is not started, you can give 4 mg per kg. And if it is a difficult airway, you have given rocuronium, but you are not able to ventilate or intubate, you want to immediately reverse after administering the rocuronium, then you have to give 16 mg per kg. Okay, so three different times: moderate block, intense block, and immediate reversal. So moderate block 2 mg, intense block 4 mg, immediate reversal 16 mg per kg. What are the side effects of this sugammadex? Since this drug has come into the market, it's available now freely. Definitely you can expect this question either in your Viva, in the afternoon session, or in the Osce. So please be thorough with this drug.
Anaphylaxis.
Hypersensitivity,
Very good.
bitter metallic taste,
Okay. Nausea, vomiting. Common side effects are vomiting, dry mouth, tachycardia, dizziness, and hypotension. Okay. So all something related to the, and you should respond. Now you are shown two ECG tracings here. Okay. The question is, what is seen in these two EKG tracings?
Second one, atrial flutter.
Atrial flutter, atrial fibrillation. In the arrow marks shown here, they indicate that it's atrial fibrillation. Here it is given something like D and N. So this is a little difficult ECG. So unless your cardiac anesthetist or some well trained in cardiac anesthesia, it's difficult to identify. I agree with that. So the left one shows a heterotropic heart transplant, and the right one shows a orthotopic heart transplant. Okay. So what is the difference between these two? Heterotropic heart transplant and orthotopic heart transplant. Nowadays, heart transplants have become very common. So that is why I included this question in the Osce session. Which other transplant, which other organ transplant you do as heterotropic, and which other organ transplant you do as orthotropic?
Kidney is a heterotropic.
Kidney
transplant.
you do heterotropy. You don't keep it in the same place where the original kidneys are. You are keeping it in the right iliac fossa. Whereas liver,
Orthotropic, sir.
you do it in the, you dissect out the deceased liver and fix it in the new liver, donor liver in the same area. Okay. But with heart, you can do both. You can do heterotropic or you can do orthotropic. So how is it done? What is the other name for this heterotropic heart transplant? It is also called piggyback heart transplant or double heart transplant. So how does it look like? This is how it will look like. If it is a heterotropic, you will have two hearts. The original heart will be there, the new heart will be fixed, and only the vessels will be attached. Whereas in the orthotopic, what you do is you clamp the aorta pulmonary artery and then cut out the deceased heart and then fix all the vessels of the donor heart with the vessels, aorta, pulmonary artery, and all that. So there will be only one heart left out in a orthotopic heart transplant. Whereas a patient who undergoes heterotropic heart transplant, he will have two hearts. The original heart also will be there in position, and the new heart will be directly connected to the vessels so that it can receive the blood and pump it into the circulation. So that is where the ECG will differ. It will be a donor liver, and this is the native. That is why the D and N here, it indicates the contraction by the donor heart, and the N indicates the native heart contraction. So you will have two PQRST, the QRS complexes, because the normal, the left out native heart also will be contracting, and that will also produce a complex. Whereas in a single thing, it will be almost like a normal ECG only. So that is the difference between the two. Mention few physiological changes in the transplanted heart. How does a transplanted heart behave?
No sympathetic activities.
No sympathetic activity.
Sympathetic and parasympathetic.
Or parasympathetic. Yeah, it is denervated out of vagus. So it goes out of vagal control. So it works only on its own inherent sympathetic stimulation. So there will be always resting tachycardia, 90 to 100 beats per minute due to vagal denervation. That is the first point. Any other points you know? Absence of response to carotid massage, because all the maneuvers that you do based on the vagus, that will not work here. So absence of response to carotid massage, Valsalva, or atropine, pancuronium, pethidine, neostigmine. All these drugs won't have their normal effects. And the last is normal response to endogenous epinephrine and norepinephrine. And drugs like isoproterenol, dopamine will have the effect on the heart. And intact FS mechanism, that is fractional shortening mechanism, metabolic regulation of coronary blood flow to the transplanted heart is mainly from metabolic response, demand based on the demand. It is not controlled by the other nervous supply and other things like a normal heart. And it responds to local pH and PCO2 changes, and normal electrical impulses and conduction will be there. So these are all the features of the transplanted heart, which you have to remember. So if you know this physiology only, you can give anesthesia for a patient who comes for an incidental surgery with a transplanted heart. That is going to be very frequently happening in future, because many patients undergo heart transplant, and they may survive for another 5 years or 10 years, and they may come for an incidental surgery. So you have to know all the behaviors of the transplanted heart, then you can manage them easily. What is shown here? There are two pictures, A and B. A shows that's a type A blood donor, anti-B agglutinations of type A, no agglutination. Whereas in type B, the B picture, it's a type B blood, anti-B blood agglutinations of type A. So agglutination is happening and hemolysis is happening. So what is A indicate? What does B indicate?
ABO incompatibility.
ABO. A indicates a compatible blood transfusion, okay, whereas B indicates a mismatched or a wrong transfusion.
Mismatch.
So it's a transfusion reaction due to wrong group blood administration, especially this B indicates that you give a patient, A group patient with a B group blood, then these are the things that will happen. Whereas if you give a correct A group, no agglutination will happen, it will be a normal transfusion. So this picture is mainly to show the mismatched or a wrong transfusion. What are the signs and symptoms of mismatched transfusion? If you give a wrong group, further things will happen to the patient.
Febrile illness, sir. Fever, tachycardia, chills and rigors,
Very
rashes.
good. Yeah, excellent. Patient will be restless,
Stress.
may have rigor, hypotension, tachycardia, fever, and rash. All these things are the features of mismatched transfusion. So how will you treat that? Once you diagnose a mismatched transfusion, how should this be treated?
Immediately stop the blood transfusion.
First and foremost, you stop further transfusion. Excellent. That is the first and foremost thing you have to do. Very good. Then, how do you prove that it is a wrong or a mismatched transfusion?
Direct comb DCT.
No, all those things. To do that, what should you do in case this happens in your career? How do you safeguard yourself? Okay, stop transfusion immediately. That's the first and foremost treatment. Second, send patient's blood and the remaining blood to the sample of patient's blood and the remaining blood in the bottle back to the blood bank. That is the second thing you have to do. So take a patient's blood sample and whatever blood is left out in the transfusion set, you send it back to the blood bank. Give IV fluids, inotropes and vasopressors if there is a hypotension and hemodynamic instability. Oxygen supplementation to be given to the patient. Induce diuresis with 50 grams of mannitol or 80 milligrams of furosemide. This is a very, very important step to wash out the hematine that has been released. And hydrocortisone 100 milligram IV to be given. So these are all the steps that you have to follow. Okay. What are the methods of doing cross-match before transfusion? How do you make sure that it is a compatible blood? This is a knowledge which we have to possess as anesthesiologists. We are the ones who use the maximum blood transfusion in any hospital. So we must know how the cross-match is done. There are three methods. One is computer cross-match. Nowadays, that is the most commonly done. Then other thing is called immediate spin cross match and anti-globulin cross match. So these are the three methods by which cross match is done. What are the immediate and delayed reactions to transfusion? Even if it is not a wrong or a mismatched transfusion, still you can have some reaction to transfusion. What are the immediate and delayed reactions that can happen because of blood transfusion?
So immediate reaction, chills and rigors.
Very good. So immediate within 24 hours, you can get acute hemolytic reactions, you can get allergic or anaphylactic reactions, you can get circulatory overload, you can get fever, you can get metabolic acidosis, you can get hyperkalemia, you can get sepsis, or you can get transfusion related acute lung injury. Okay, these are the 8 things you have to remember. You can get acute hemolytic syndrome, you can get allergic anaphylaxis, circulatory overload, fever. Fever is the most simplest and the commonest thing that can happen. Of course, you can get acidosis, hyperkalemia, especially in a very old blood. Hyperkalemia is very, very common. Okay? And delayed reactions are delayed hemolytic reactions, alloimmunization, graft versus host disease, viral and parasitic infections can happen. Okay, so these are all the points. This is a topic which is not commonly discussed, but you may get it in the exam, and some clever examiner will try to check whether you know all these things, because this is not a very commonly taught subject. Now I am going to show pictures of airway adjuncts, out of which one is an odd man out, which does not belong to that group. I'll show the pictures, you have to identify them. What are these things? You are seeing 3 things in one picture. I think this should be very easy. The middle one is very easy. This is ray tube, but what about these two? Nobody is answering? Okay. This is called the preformed tube. This is like bent like a U. This is called the preformed endotracheal tube. This is an oral ray tube. This is the Oxford tube, which was used for cleft lip and palate in the era before the RAE tube was introduced. This is the Oxford tube. In some hospitals, they may have this tube still as a museum specimen and show you. So it is just like an L with a beveled end, and they give this. Usually, it used to come only in red rubber in those days. And this is the tracheal end which goes into the trachea. This end will be soft, whereas this end, which is the connector end to the circuit, will be more thicker. So this is the Oxford oral tube, which was used in the olden days for cleft lip and cleft palate surgery. Please remember this. This will be in red rubber color. And this is the common oral ray tube, which most of you are familiar with. This is called the preformed oral endotracheal tube. And this is, of course, many of you would not have the chance to see this. This is a tube of our era. When we were postgraduates, we never had this sort of disposable tube. We used these tubes repeatedly again and again, washed and dip it in hot saline and bring it and use it. Reusable red rubber tubes. By which route you can introduce this tube? Please make a guess. See the curvature, is it looking more acute or more obtuse?
Nasal, sir.
This is a nasal red rubber tube. Nasal plain red rubber tube without any cuff. Okay, it's a nasal plain red rubber tube. What is this?
Oral cuffed red rubber tubes.
Oral cupped red rubber tube. Excellent. That's all. Okay. So if these things are available in any of the hospitals, unfortunately, when you go for your practical exams, they may just show to bully you or tease you or rag you, because these things are nowadays not used at all. But that doesn't mean that they cannot ask you. The examiner can still ask you this. So this is a red rubber. You can see the curvature difference. This is more obtuse and this is more acute. So if that is how the examiners in those days used to ask us, how do you differentiate between a nasal tube and an oral tube? Nasal tube, this arc is more, this radius of curvature is more. For this curvature, I mean, this is less, this is more acute, this is more obtuse. So that is the major difference. And that is a bevel. And this is a high pressure, low volume cuff. So even if you put just 5 ml, the cuff will be very tight. So this is a high pressure cuff. This used to cause more damage. Okay, and that is why we changed it to low pressure, high volume cuffs nowadays to avoid the damage. Okay, so this is the cuffed oral rubber tube. What is this tube?
Hexametallic tube, sir.
So metallic. You find a spring-like structure here. This is looking more plain, isn't it? This may at least, what you say, may agree, look like that. But this is a Montandon tube. You know where it is used? I have given you the name. It's called Montandon tube. It's used for which surgery? It's used for total laryngectomy, where you do a tracheostomy and then introduce this tube. So this will be lying on the chest and you can inflate the cuff. So this is the acute bend. So it is something like a tracheostomy tube with an extended body. Okay, so you put this end into the tracheostomy opening, and this tube will be fixed to the chest, either with a suture or with a plaster, and your connection, the circuit, everything will lie on the patient's chest and abdomen. Okay? So this is a Montandon tube used for total laryngectomy surgery. Because you would not have had the chance to use that, but the examiners can anytime ask you all this. So what are the things? There are 5 things given here: A, B, C, D, E. What are they used for? These are also things which were used in the past. So because of historical importance, they may ask you. History is part of our questioning. Can come in your theory or in your viva or in ASCII. So what do you think is the use of these things? At least this you should be able to identify.
Connector.
Yeah, this is a
Connector.
connector.
Universal.
Tube connector. This is a universal connector. E is a universal connector or a connector made in the correct present day tubes. But these are all older connectors, okay, for endotracheal tube. And the names are, these are called ET tube connectors, endotracheal tube connector. The A is called the Cardiff connector. Okay, so this serrated or corrugated thing goes into the patient's endotracheal tube, and this side arm will be attached to the circuit, and this chain with a cap, you can remove this and then put your suction through this and suck out any secretions and close it again. Okay, so this is the fresh gas flow inlet. This is the ET tube insertion space. This is for suctioning. This was also called Cobb's suction unit. COBB apostrophe S, Cobb's suction unit. Some hospitals, as I told you, may still have this piece left in their museum or in their department. So they may suddenly give you, if you have to get the best mark out of this, if you answer all the other questions very well, they may test you with the knowledge of old equipments. So remember this. This is called the Cardiff or Cobb's suction union. We used to call it as a suction union. So without interrupting or disconnecting the patient, you can imagine their nice ideas in those days itself. So the patient will still receive the fresh gas flow. You can just open this, put your suction tube inside, suck out, and then close the suction port with this cap. So this is the Cardiff. Then this is the McGill connector. In those days, this is a common thing to use with the red rubber tube. This will be there, and there will be another adapter to call this McGill connector mount. Then the C is called the Oxford connector, and the D, this bent, is called the Penlon connector, and the E is the common Portex tube, which came in first as a disposable tube. This is the universal connector, which is coming with all the tubes nowadays. Okay, so remember all these different types. What is this?
Yanker suction cannula, sir.
Huh?
Yanker suction cannula.
Yankers. This is sterile Yanker suction. So it is inside a packet. It has not been opened. So it is sterilized and can use it as a sterile suction pattern. So this is a sterile Yanker suction. If it is not with this plastic bag, you can say just Yanker suction. But when it is enclosed inside a plastic bag, it means that it has been not opened at all. It is a sterile unit which you can use. What is this? All of you would have used it during COVID time.
Closed section catheter.
Fantastic, very good. Yeah, closed suction catheter, right. So what is this?
IV sets.
IV fluid set, sir.
Why so
fluid
much
drip
delay
set.
for this? Okay, this is the disposable infusion set. So which is the odd man out in this group?
Disposable infusion sets. Sir.
This is the odd man. Okay, this is not used for airway. So this is the odd man out. Okay, right. Now, what is the pathological condition shown here? Person with an open mouth, swelling underneath the tongue, as well as you can see the swelling here.
Ludwig's angina.
Excellent, very good. It is Ludwig's angina, bacterial infection involving floor of mouth and cheek, neck rather. What are the causes of this condition? Why does it happen? Already we have given that bacterial infection is there. But what causes this bacterial infection? What other condition can lead to this bacterial infection?
Tooth infection. Submandibular.
Dental infection, parapharyngeal abscess, fracture mandible with piercing injury, submandibular salivary gland stones. Okay, so these are the 4 things which can lead to this Ludwig's angina. Or what are the signs and symptoms of this condition?
Fever, pain, difficulty in breathing.
Very good. So swelling in the floor of the mouth lifts the tongue to cause difficulty in swallowing, drooling of saliva, swelling in the submandibular region can cause airway compression, fever, chills, and pain. All these things are the signs and symptoms of this condition. How is this condition treated?
Surgical management.
Straight away surgical management?
Antibiotics.
First thing is you antibiotic, analgesics, antipyretic, adequate hydration and nutrition. Okay, this is the first basic step. If swelling does not reduce or cause airway compression, we need incision and drainage. So, what are the anesthetic challenges in this case?
Difficult airway was pediatric patient.
It's an anticipated difficult airway. Do you fear the airway?
Rupture of abscess.
This is a case of anticipated difficult airway due to restricted mouth opening limited tongue mobility, and submental swelling. So that is the reason for the difficult airway. It can be managed by either fiber optic or blind nasal intubation under topical, or rarely tracheostomy may also be needed. So that's how the airway is. What is shown here? Please go through the numbers, the waveforms, and some text which is written, everything. If you go, you can find out.
Neuromonitoring.
I can give you a small clue. Read what is
CTG.
given.
Deliberately,
CTG, sir.
Huh?
CTG.
You can get a clue from this.
Seat.
TOCO, TOCO. Huh?
Audio
TTC.
topography, sir.
Appa, fantastic. That is cardio topography. So what does this waveform indicate? You can see the number 60,
FHR.
80, 100. It is a fetal heart rate. And this
FHR.
is the intrauterine pressure. Okay? Continuous. So that's why you have to read everything very carefully. So this is the clue. Topograph. So this is the uterine section, this is the fetal section. Okay. So it is a fetal heart rate and intrauterine pressure tracings in the cardiotocograph. What are the types of fetal heart variations?
Acceleration and deceleration.
Hmm? Okay, early at the onset of uterine contraction, due to compression of the head, you may get a bradycardia, which is called early deceleration. Early deceleration, not acceleration, but deceleration. Then there will be late, after the onset of uterine contraction due to hypoxia caused by decrease in uteroplacental flow. It is called late deceleration. As you know, children, whenever they become hypoxemic, they will have only bradycardia and not tachycardia like an adult. So early deceleration and late deceleration. Then there is a variable which occurs at any time of uterine contraction due to umbilical cord compression and vagal increase in vagal tone. So these are the three types of decelerations that are happening. One is called early, the second is called late, and the third is called variable, which is a very, very important thing which can be asked in your discussion during a PIH case. They may ask you, how do you know the viability or the danger to the fetus, fetal distress? If you have a cardiotocograph, how will you identify whether the fetus is in distress or not? So at the time, they may ask you about the normal patterns or variations in SHR. So you have to remember it is early, late, and variable. What investigation can come from fetal distress identified by fetal heart rate monitoring?
Ultrasonograms.
Huh?
fetal Doppler, sir.
Ultrasonograph.
The second person answering voice is not clear to me.
USG, sir.
Fetal scalp blood sampling for acid-base estimation will confirm whether the fetus is in distress or not. So how to do intrauterine fetal resuscitation, supposing if the fetus appears to be in distress? How do you do the intrauterine fetal resuscitation? You have to improve the oxygenation to the fetus, isn't it? That is the resuscitation. So how do you do that? Tocolysis, that is, you don't allow the uterus to contract too vigorously, especially if it is a cephalopelvic disproportion. You have you are planning for cesarean, but things are getting delayed. The time if the fetus is in distress, you do tocolysis, administer fluid to the mother, and make the mother go into what is called knee chest position to take the weight of the IVC and aorta. So ask the mother to go into what is called the knee chest position, oxygen supplementation to the mother. All these things will help in resuscitating the fetus. What is exit procedure?
Exit
Zero.
through intrapartum
So
procedure.
intrapartum.
Exutero intrapartum treatment. Okay, that is it. What is this patient suffering from? Probably she is holding her back, and something like a lightning is being there, and the spinal vertebral canal is shown there as a clue for you to identify the condition.
Scoliosis.
Shirt, t-shirt she is wearing shows the picture of the vertebral canal, and somewhere there she is having a severe problem.
Disc prolapse.
Scoliosis.
Probably suffering from low back pain. Okay. What are the classifications of low back pain? How do you classify low back pain? Nowadays questions come in pain management, chronic pain, acute pain. You can get questions on that. So you can classify low back pain into acute and chronic based on the symptoms or the duration. It can be classified as acute if the symptoms are less than 6 weeks, and chronic when the symptoms last for more than 3 months. So the differentiation or classification is acute low back pain, symptoms less than 6 weeks, and chronic back pain and symptoms are more than 3 months. Can also be classified as specific when there is a specific pathology like herniated disc, infection, tumor, osteoporosis, inflammation, or fracture, or it can be non-specific when no identifiable cause is found. Okay, so these are the two classifications you have to remember. What mnemonic can be used to assess the nature and severity of low back pain? So OPQRST is a mnemonic to remember. O for onset, whether it was spontaneous or triggered. P for pattern, where is the location and timing of pain. Q for the quality of pain. R for factors relieving or exacerbating. And S for severity and systemic effects. And T for treatment taken. So if you remember OPQRST, you can easily take all the history relevant to low back pain. Onset, pattern, quality of pain, relieving or exacerbating factors, severity, and treatment. What is SLR? How is it done? What does positive SLR indicate?
Single leg raising test, sir.
Straight leg raising test is
Straight leg.
SLR. Very good. How do you do it? Don't say only orthopedic surgeon will do, I won't do it. If you are going to practice pain medicine, you should know this.
Ask the patient to lie down straight on the cot and lift
Very
the leg
good.
without bending the knee.
Excellent. That is very important. That last point is very important. Without bending the knee, ask the patient to elevate the entire lower limb, painful side, straight up. And what does positive SLR indicate?
Patient disc prolapse or pain.
Lordosis.
Patient will experience pain. If there is a pathology, patient will experience the pain when they lift it more than 60 degrees. Okay. SLR is a expansion straight leg raising test. Patient lying supine, affected leg is raised without bending the knee. That is very important. Positive test causes radicular pain between 30 and 70 degrees of elevation, indicating decreased mobility of dura mater. So that is the why they happen. This pain is this is the reason. What is quada equina syndrome and manifestations and management of that pain?
Due to preservatives in
Carda equine syndrome.
It occurs with
No.
using lignocaine as final anesthesia.
Should it always occur only after the spinal anesthesia? Can't you get
No, sir. Traumatic means compression of the nerve roots of lumbar spine.
What do you understand by that term, first of all? Carda equine. Equine means horse. Carda means tail. So how does a horse's tail look like? It looks with a lot of hair, isn't it? Individual. So
Yes.
all the nerve fibers, that is why the name is given. Occurs from any lesion compressing the carda equina nerve roots. Okay, that is the reason. It can affect like manifest like a bowel bladder or sexual dysfunction, involvement, features of back pain, lower limb weakness, or sensory deficit. All this can be there. So how is it managed? Is it an emergency or an elective procedure? If a patient comes with severe bowel bladder involvement,
Emergency, sir. Urgency or
Huh?
emergency.
It's an urgent decompression is the treatment to be done within 24 hours of onset. It's a very, very important thing which you have to know. So it's one of the emergency indications for back pain. What is shown in this? What is the name
Targeted
for this
infusion.
arrangement?
Target controlled infusion.
Target control infusions.
What are these things first of all? These are all
Syringe pumps.
syringe pumps, infusion
Syringe
syringe
pumps.
pumps. Okay, 3 different pumps are there. So if you arrange them one below the other, what is the name for that arrangement? All of you nowadays masters in ICU and cardiac anesthesia and all liver transplant and all these things where you see these things very, very commonly. Nowadays, we have never even had a chance to look at these instruments. 3 syringe pumps used for either TIVA or TCA. This arrangement is called stacking. You put one below the other. You can put 3, 4, 5, 6 also. So it is called stacking of the infusion pumps. What is the basis of TIVA?
Sir, induction and maintenance of general anesthesia by drugs, intravenous drugs only, and no inhalational agent.
What is the basis? Intravenous administration of first a bolus, then a continuous infusion of anesthetic drugs to maintain a state of surgical anesthesia. This is the basis of TIVA. What are the advantages and disadvantages of TIVA? First advantages, then disadvantages.
So better hemodynamic
Advantages
control.
are
Sir.
you are avoiding inhalation anesthetic agents, which reduces OT pollution and decreases the potential for global warming. And useful in surgeries where you have to use laser, or disadvantages are I just shown it in a flash.
Risk of awareness. Sir. Risk of awareness. Multiple drugs, combination of drugs.
Expensive equipment needed, concomitant depth of anesthesia monitoring is needed, context sensitive half time to be used for stopping the infusion. These 3 points are you have to be very, very aware of these things. So that is the disadvantage. If you don't know when to stop the drug, you will be keeping the patient asleep even after the surgery is over. And all these equipment, they don't come so cheaply. They are all quite expensive. And whenever you use TIVA or TCA, it is mandatory nowadays that you also measure the depth of anesthesia. What are the specific indications for usage of TIVA?
Malignant hyperthermia history. History
Malignant
of
hyperthermia. Excellent. Very good. Very good. Then?
Sir, PONV, FBEL score means high risk of PONV.
Very good. High risk of PONV. Very good. Then?
Sir, scoliosis means intraoperative awakening of the patient is required. Like in scoliotic surgery.
Neuromonitoring cases where you want to do neuromonitoring, where you want to avoid muscle relaxants or inhalation agents, excellent. Then any surgery where you don't want to intubate but do something in the airway. So
Yes,
non-tube or tubeless airway surgery. So
Tubeless.
these are the indications. Malignant hyperthermia risk or patients with long QT syndrome or history of severe post-op nausea and vomiting, tubeless thoracic or ENT surgery, NORA, that is non-operative room anesthesia, daycare surgery, some neurosurgery, myasthenia or neuromuscular disorders to avoid neuromuscular blockade, or cases with anticipated difficult intubation or extubation. In all these cases, you can use TIVA. Okay. What is this person likely to be suffering from? Look at what is the person holding in his hand and how he is opening his mouth and clutching to his chest.
Asthmatic, sir. Using
Inhaler. Most probably is suffering from bronchial asthma. You can see the inhaler in the hand and he is opening his mouth to trying to breathe. And he is holding his chest, tightness in the chest. That is how they describe the feeling of dyspnea. What is asthma and what are its characteristics? Again, I want to remind that you have only 4 minutes for each question in the exam time. So practice in such a way. Come out with the answers quickly. Is it an obstructive disease or a restrictive disease?
Reversible.
It's an obstructive airway disease. Why can't you just say that at least? There is an obstructive airway disease. Features are it is a reversible obstruction of small airways. That is all. Inflammation and mucosal edema is also happening there, and increased mucus secretion is there. So these are the features. How is asthma classified according to National Heart, Lung and Blood Institute? I don't know how many of you have heard this classification or this about this NHLB Institute. Any guess? How can asthma be classified? Okay, right. It can be mild. 4 stages are classified. One is called mild intermittent, where the asthmatic attacks happen less than 2 times per week, and the patient never, very rarely gets nocturnal awakening, less than 2 times in a month, and the peak expiratory flow rate to FE1 between attacks is more than 80% of the predicted. So it is a very, very mild form, mild intermittent attacks. The second thing is mild persistent, and they get attack at least once a day, and they wake up at least more than 2 times per month. Still their PEF FE1 is more than 80% of predicted. Moderate persistent is daily they get, and their waking up is more than once a week. And here the PEF and FE1 start decreasing. It goes down to 60 to 80%. And in severe persistent, continuously they get the attacks. Their waking up in the night is quite frequent, and their PEF FE1 ratio is less than 60%. So these are the 4 stages or classes of asthma according to National Heart, Lung and Blood Institute. Mild intermittent, mild persistent, moderate persistent and severe persistent. Now the next question is, how is asthma treated according to the above classification? Supposing this, you ask the history, a patient who says I am an asthmatic for 15 years, and you classify them under these categories. You should know, supposing there is no pulmonologist available, and you are nowadays we are trying to be pre-operative physicians. Anesthetists are being considered as perioperative physicians. So without referring to anybody, we should know how to treat a patient and prepare them, optimize them before surgery. So if the patient comes under any of these categories, how do you treat them?
Sir,
What do you do for
SABA,
mild intermittent? First category,
Sir,
first stage.
short-acting beta agonist.
Inhaled, short acting, inhaled. Okay, inhaled therapy is now recommended. So inhaled short acting beta agonist for mild first stage, mild intermittent. Supposing it is mild persistent.
Sir, along with that, inhaled steroids.
Inhaled steroids, very good. So along with short acting beta agonist, inhaled steroids. Supposing it is moderate persistent, third stage.
Sir, short-acting plus long-acting beta agonist plus inhaled steroid.
Steroids. And if it is severe persistent,
Systemic steroids plus inhaled long-acting beta
that's all.
agonist.
That's all. Very good. So mild, only short-acting beta-2 agonist inhaler, mild persistent, that is beta-2 agonist inhaler plus inhaled steroid or leukotriene antagonist, like your euphotorium bromide and all those things. Then moderate persistent, medium dose inhaled steroid plus long-acting beta-2 agonist. So this is the treatment for moderate. For severe persistent, high dose inhaled steroid, long-acting beta-2 agonist, and oral steroids also. Okay, so these are all the treatment recommended for the 4 stages of asthma. Now here is a case scenario. A 62 years old man with CAD and emphysema undergoes Whipple's procedure for CA pancreas. He is being ventilated post-operatively and suddenly he develops hypotension with a BP of 60/30 and a tachycardia of 130 per minute. What are the causes of post-operative hypotension?
Bleeding,
Slippage
sir.
of the ligase.
Bleeding.
Okay, bleeding. The question is causes, not cause. Only one cause. You have to give many reasons.
Known CAD means
Cardiac failure.
Cardiac failure. Okay, very good. Cardiac failure. Excellent. Then
Sepsis.
See, this is where you have to develop a plan of concepts. Okay, you must know all the basic concepts of how to treat a patient if they develop sudden hypotension. So in the cardiac physiology, what are all the causes when the patient can become hypotensive? There are preload, contractility, afterload, like that, isn't it? So all these things are very, very important. That is why I took a class on basics of CVS. Okay, so if you think in that term, you will be able to answer that. The first thing is decrease in preload. Supposing there is a decrease in blood volume, either you have not given enough fluids, or there is a postoperative bleeding, or there is a third space loss, or obstruction to venous return in the form of cardiac tamponade or a tension pneumothorax, because he is being ventilated. There may be an IPP or a PEEP. So all these things decrease the preload coming to the heart, which may be the cause of hypertension, number one. Second thing is decreased contractility, which may be because of the anesthetic drugs extended action, or a myocardial ischemia or infarction because he is a CAD patient, or it may be electrolyte disturbance, or it may be a dysrhythmia or hypothermia. The third is decrease in afterload, either a residual effects of RA or GA. You have put in an epidural catheter for pain relief, and somebody gives a instead of the diluted dose, they give a split dose of local anesthetic, and it produces a thoracic epidural causing a sudden vasodilatation. Okay, or vasodilators used, or anaphylaxis, sepsis. All these things cause decrease in afterload, which may be the reason for hypotension, or it may be because of rate disturbance, extreme bradycardia or tachycardia. All these things could be the reason. So if there's a BP of 60/30 and heart rate, you may call it as a shock, isn't it? Patient received shock. So what is the definition of shock and what are the types of shock?
Obstructive, distributive, circulatory, and
First of all, define shock. What is the definition of shock? That is the first half of the question. Second half is only the types.
perfusion, reduced perfusion to the tissues.
Shock is defined as failure to meet the tissue oxygenation or oxygen requirement. Simple as that. Tissues are not getting enough oxygen. Either it may be because of anemia or because of hypotension, or it may be because the heart is not pumping well. So whatever is the reason, ultimately the tissues are not receiving the oxygen they require. So mitochondria are suffering from want of oxygen. That is defined as shock. And the types are, it may be cardiogenic, obstructive, hypovolemic, or distributive. Okay. So how do you treat this above patient? We have seen what is shock. We have seen what are all the types of shock. Now, and we know what are all the causes for postoperative hypotension. So with this, all this knowledge, how will you treat the above patient?
Read the cause, sir. What is the cause?
First identify what is the shock,
Sir.
what type of shock the patient is. Since it has happened in the post-op time, rule out hypovolemic shock due to bleeding or third space loss, number one. Then what other things can be the cause in this patient? Supposing drain is not that high and there is no sign of any blood loss or fluid infusion has been quite done correctly, so there is no hypovolemia as it is, then what could be the next step or what could be the next cause you can think of?
Pump failure, cardiac.
Cardiac failure. Next is rule out poor myocardial contractility. Since patient has history of CAD, do an urgent EKG and bedside echo and biomarkers may help whether he has developed a postoperative myocardial infarction or not. That is the second step. Then what is the next one? After ruling
What
out
are the causes for
hypovolemia,
afterload?
lastly rule out distributive or obstructive causes as patient has got emphysema also. So this is the importance of the history that is given. So that may produce distributive or obstructive causes. And invasive monitoring, central venous pressure, PA pressure monitoring, cardiac support, fluid resuscitation may all be needed. Okay, that is how you treat this patient. What is the abnormal feature seen in this patient?
Process, sir.
So the patient has drooping of both the eyelids. Okay, bilateral. What condition this? In what condition this can be seen?
Myasthenia, sir.
Myasthenia is one. Okay. Should it always be myasthenia?
No, sir.
Thyroid is hypothyroid.
Thyroid, hypothyroid, you get ptosis. I have not read anything like that. Can it be congenital? Familiar? That's a very common thing. This happens in congenital ptosis or myasthenia gravis. It doesn't happen in hypothyroidism at all. Please don't fail that happen in the examination. Okay? How to differentiate between these two conditions?
In myasthenia, other muscles will also be involved slowly and slowly.
Okay.
And with fatigue, it will increase.
Which remains the same throughout day or night. Okay, whenever you look at the patient, the eyelids are always drooping. Okay, whereas in myasthenia, morning they may be looking normal. The eyelids may not droop this much, but as the day progresses, when they do their normal routine activity, the weakness sets in and the eyelids start drooping. Okay, congenital ptosis is present from birth and remains static. Motor power in this patient is normal, whereas myasthenia happens very much later. The drooping is less in the morning and increases during the day. There is progressive muscle weakness as it is due to presence of IgG antibodies against the acetylcholine receptors at the neuromuscular junction. Okay. How do you anesthetize this patient? Supposing this is a myasthenia patient and he requires a thymectomy. How do you anesthetize this patient? Have any of you given anesthesia for thymectomy during your training period so far? Not the quite rare surgeries. But if there is an endocrinology team, then maybe you may be getting these cases here. Okay, pre-op evaluation. Assess the severity by checking the muscles involved and the treatment received and presence of any other autoimmune disorders and whether there is any bulbar or respiratory muscle involvement. This is the first pre-op check you have to do. Then optimize the patient with anticholinesterase drugs like pyridostigmine, neostigmine, and they may be sometimes given steroids also because this is an autoimmune disorder. They may receive steroids or immune modulators. And rarely, in severe cases, they may undergo plasmapheresis also to remove these antibodies. And thymectomy is done in two ways. It can be done by a median sternotomy or it can be by video assisted thoracoscopy. So standard induction with RSI. Why RSI? Because these patients can have a reflex when they aspirate and avoid neuromuscular blocking drugs. And if needed, you can give atracurium in reduced doses because that can be easily reversed. And maintenance with volatile or TIVA is the method because we are not going to use neuromuscular blocking drugs. And ensure full recovery of muscle function before extubation. Avoid giving any reversal, especially neostigmine. This is where you use rocuronium, sugammadex may be used. That may not cause much problem. So avoid reversal to avoid cholinergic crisis. What factors help to predict the post-operative ventilatory support in these patients? Supposing this patient undergoes thymectomy, how can you predict the pre-operative phase itself whether this patient will require post-op ventilation or not? This is an established case of myasthenia.
Sir,
So what
Levanthan
factors?
and Hirsch scoring. Levanthan and Hirsch scoring, sir.
Okay, what are the things, components of that?
Sir, history of COPD, duration of myasthenia since
drug use, duration of drug dosage. Okay, the disease duration more than 6 years. Daily pyridostigmine dose required more than 750 milligram. Presence of any chronic lung disease, or if the vital capacity is less than 2.9 liters, these patients may definitely require post-op ventilatory support. So these 4 points you have to elicit during the pre-operative phase itself. With the duration, they have been diagnosed with the disease for more than 6 years, or if their daily pyridostigmine dose requirement is more than 750 mg, or if they have some underlying lung disease also, as we mentioned, and if the vital capacity is less than 2.9, they may require elective ventilation post-operatively. So concerning cephalosporins, that is the antibiotics which we use, which are the statements which are false or true? Is it the third generation cephalosporins have better activity against gram-positive organisms than first generation?
false.
False. Okay. Just make a note of it. We'll see the answers at the last. Cefuroxime has powerful action against methicillin-resistant Staph aureus.
False.
Take a guess at least if you don't know.
False,
Also
sir,
true.
false.
False. So first two answers you have said false. Okay. Ceftazidime can be used for atypical pneumonia.
Ceftazidime.
If anybody is going to plan to become intensivist, this knowledge is very, very important. After your qualification, if you plan to take up, become an intensivist and manage patients in ICU, without this knowledge, you cannot survive.
True, sir.
So,
Very sure.
they exhibit good CS of penetration, cephalosporins.
Yes, sir. True, sir.
True. Okay. All work on efflux protein on cell wall.
Don't know, sir.
Hey, true or false? Let us see the answer. Let's okay.
True, sir.
So only one is true. That is, they exhibit good CS of penetration. That is the only true thing about this. All the others are false. Okay. They don't have greater activity against gram positive. It is not useful against MRSA, and it is not useful in atypical pneumonia.
Typical pneumonia.
And it doesn't work on efflux proteins on cell wall. Okay.
Yes, sir. Yes, sir.
Now the other group of drugs, carbapinums. All of you would have experience using it in ICU, especially in patients with severe sepsis. They are beta lactams, useful in enterococcal infections. They are paired with quinolones for bowel perforations, and they are first line for coliform urosepsis and useful in pneumococcal pneumonia. All these are the 5 things which are all true, which are all false. They are beta lactams. Is it true or false?
True, sir.
True.
True, sir.
Very good. Very easy answer. Useful in enterococcal infections.
True
or
or
false?
gram negative.
False. Paired with quinolones for bowel perforation. First
True,
line
sir.
for coliform urosepsis.
Yes, sir. True, sir.
True. Useful in pneumococcal pneumonia.
False, sir.
So the answer is first and fifth only
Yes,
are
sir.
true. That is,
True,
their
true,
beta
true.
lactams is true. They are useful in pneumococcal pneumonia is true. All the other things are false. It is not useful in enterococcal. It is not combined with quinolones. It is not the first line for coliform urosepsis. So that is about carbapinums. Then there is an organism, Pseudomonas aeruginosa, can be well treated with the following antibiotics: colistin, cefuroxime, ceftazidime, gentamicin, and linezolid.
Ceftazidime only.
Linezolid, sir.
Ceftazidime and linezolid.
A, B, C, D, E.
C and D.
Out of which is
CNE.
the... So first is true. Colistin is useful. Cefuroxime is not useful. Ceftazidime can be used. Gentamicin can be used. Linezolid is not useful. So two drugs which are not useful are cefuroxime and linezolid. All others, colistin, ceftazidime, and gentamicin, are useful against Pseudomonas aeruginosa. About linezolid, it has high bioavailability, can cause bone marrow suppression, and it's effective against, what is VRE? Any idea?
So vancomycin resistant
Vancomycin
enterococcal
resistant enterococci. Very good.
UTI.
Vancomycin resistant enterococci, and efficacy confirmed to gram-positive organism, acts on cell wall protein. Which are all the things which are true and which are false? Anyway, these 4 things are true. It has high bioavailability. It can cause bone marrow suppression. It is effective against vancomycin resistant enterococci. The efficacy confined to gram-positive organism, but it acts on cell wall protein is not true. About vancomycin, it is rapidly bactericidal, the first line drug against MSSA, effective against enterococcus, effective against coagulase negative E. coli, and causes hypertension if infused fast.
Bactericidal.
A true, B true, sir.
B.
A true, B true. So two T's. Okay. What about C, D, E? Okay, you will have to read up. Anyways, A is false, B is false, C effective against enterococcus, effective against coagulous negative is Zika, and E is it causes hypertension is also false. Only two are true. That is effective against enterococcus, effective against coagulous negative enterococcus. Regarding methicillin resistant staph aureus, it's a gram-positive aerobic rod. It causes excess of mortality in critical care patients. Can consider fully eradicated after 3 negative swabs. Only 3 choices here.
So A
With
is
a gram
true.
positive, A is true.
No, sir. Cocci. Staph aureus is cocci, not rods. Bacilli also.
Causes excess mortality in critical care patients. Can consider fully eradicated after 3 negative swabs.
C true हो सकता है.
First is false. It is not a, as you said, it is a cocci, not a rod. So false. Causes mortality in critical care patients. It's one of the true reasons, and it can be considered as fully eradicated if you get 3 negative swab results. The extended spectrum beta lactamase producers. They are first described with Pseudomonas, then remain sensitive to tazosine, sensitive to meropenem, common in neurology patients.
C and D true, sir.
C and D true. Okay, so we'll quickly go. Yeah, you are right. C and D are true. First two are false. First described with Pseudomonas, not correct. It remains sensitive to tazosine, that is also not correct. They are sensitive to meropenem and it is common in urology patients. That is extended spectrum beta lactamase producers. So that question was mainly to tickle your interest in ICU care, mainly for antibiotic knowledge. Now what is shown here?
Cervical plexus, sir.
Sir, ansa cervicalis.
Ansa cervicalis is written.
Cervical plexus.
Cervical plexus. The cervical plexus formed by C2, C3 and C4. Very good. How is cervical plexus classified anatomically?
Superficial and deep, sir.
Superficial and deep. Excellent. Classified into superficial and deep. What are the branches of cervical plexus?
Sir, greater auricular nerve, lesser occipital nerve. In
Correct.
Now to strap muscles.
Lesser occipital, greater auricular, anterior cutaneous nerve of neck, supraclavicular. These are the 4 branches. Lesser occipital, greater auricular, anterior cutaneous nerve, and supraclavicular. What are the indications for superficial cervical plexus block? When will you practice that?
Thyroid
sir, for
surgery.
IJV central vein catheterization.
Central
For
vein.
catheter endarterectomy.
Hmm.
For thyroid surgeries.
Thyroid surgeries, both sides or single side?
Bilateral.
Both sides, sir. For lymph node excision biopsy.
Very good. For surgeries on the anterolateral part of the neck, like carotid endarterectomy, that is the first and foremost indication, especially in elderly people where you don't want to give GA. Carotid endarterectomy is a very, very important indication. And the unilateral thyroid gland, because you don't, you are not supposed to administer, especially bilateral deep cervical plexus block. You know why? If you want to do a bilateral thyroid excision, that is a subtotal or total thyroidectomy, you are not supposed to administer deep cervical, because for thyroid you have to give not only superficial, you have to give deep thyroid, deep cervical plexus block also. What will happen if you give bilateral deep cervical plexus block?
Phrenic nerve will get blocked, sir.
Phrenic nerve. Patient will have a sensation of beheadedness. Patient will not feel that he is having a head at all. So that will make them jittery. Okay. So that is the reason why you are not supposed to administer trilateral deep cervical and superficial cervical plexus block. Okay, what is the technique of blocking superficial cervical plexus?
Line technique.
Position, preparation, palpation, puncture. 4 P's you have to remember.
Supine patient head turned towards the other side.
Patient lying supine, head turned to the opposite side of block. Mark the lateral border of sternocleidomastoid muscle. The point midway between tip of the mastoid process to medial end of clavicle is the insertion point. External jugular vein usually crosses near this point. You may require about 15 to 20 ml of local anesthetic for this procedure. So this is how the whole thing is given. What are the complications of this block?
Articular injection.
Mainly vascular injury, nerve
Vascular
injury,
injury.
local anesthetic toxicity, pneumothorax, all these things. Anything in the neck, you can safely write all these things. Vascular injury is the most commonest. Then nerve, LA toxicity. So how deep cervical block differs from this? Superficial cervical plexus block is very superficial. Deep cervical plexus can be
Deeper.
compared to interscalene block as a paravertebral block, because you are going close to the exit of the nerve at the lateral process, transverse process. So you have to go and kick and then withdraw a little bit and inject your local anesthetic there. Okay. So enumerate the changes occurring due to old age in a system-wise manner. What are all the changes that happen in the various systems? Geriatric anesthesia knowledge. What changes happen in cardiovascular system? What changes happen in respiratory? What changes happen in renal, metabolic, thermoregulation, musculoskeletal?
Sir, cardiovascular myocardium thickening, stiffness.
CNS. First we start with CNS. Progressive structural change with cerebral atrophy. As age advances, your brain starts atrophying. Decreased neuromuscular transmission concentration, decreased blood flow, oxygen consumption and MAC or both G and LA are increased sensitivity to benzodiazepine and opioids. So these are the CNS. Can you say something about CVS? What are the changes that happen? Huh?
Stiffening of the myocardium and the arteries. More prone for hypertension,
the
ischemic
heart rate?
disease.
Heart rate in old age.
Conduction system deranged रहेगा, so heart rate.
So they have usually bradycardia, which baroreceptors, do they respond immediately?
No, sir. Decreased response.
That's a very important point, especially when you administer regional in an elderly patient. You cannot get a required tachycardia for hypotension. Okay, that's a very important thing. So, autonomic nervous system, there is a decreased baroreceptor sensitivity resulting in postural hypotension. Temperature control impaired due to decrease in BMR and subcutaneous fat. Okay, these are the two changes that happen in the CNS and the ANS. And CVS, there is a decrease in cardiac output and heart rate, number of receptors causing less sensitivity to iron. So there is a receptor down regulation. So it causes decreased sensitivity to iron probes and risk of pulmonary embolism, anemia, all these things are there in cardiovascular system. Then with regard to RS, there is a closing volume encroaches on FRC. So you may have a trapping. Increased VQ mismatch, widening of alveolar to arterial difference, decreased response to hypoxia and hypercarbia. Airway likely to be edentulous, osteoporosis of mandible, cervical spondylosis, lax pharyngeal muscles, and osteoarthritis. And GIT, delayed gastric emptying, hypertonia, gastric reflux more common. Renal, decreased renal blood flow and GFR, concentrating ability is decreased, fluid handling, periop dehydration very common. And drug metabolism, decreased renal and hepatic function causes slow elimination, decreased protein binding, binding with a decreased receptor concentration, exaggerated response is likely. And they may have comorbidities like coronary artery disease, diabetes, hypertension, COD, COPD, Parkinson's, dementia, OA, frailty. Lastly, surgical mortality percentage is high compared to others. So this is a small nutshell for about geriatric anesthesia. So remember, all the systems are involved, starting from CNS, ANS, CVS, RS, airway, GIT, and of course we have to include musculoskeletal also. Joint mobilities are restricted, so easily they can fracture if you try to position them in the fracture table and all that. Even the non-operative side can be fractured. So we have to be very, very careful with these things. What is depicted in this picture? The clue is you are seeing two hands behind the formula that is shown there.
Local anesthetic.
Chirality.
Chirality,
Yes.
excellent. Depicts the chirality of molecules. Very, very good. Explain what is meant by chirality.
Sir, mirror images of each other. Superimposed mirroring.
Non-superimposed
Superimposed mirror
We
images
used
of
to
each
call it
other.
as telegraphic language in those days. Okay, mentioning a few words here and there. Okay, chirality is derived from the Greek meaning having handedness. It defines a particular type of stereoisomerism. There are many drugs which exist as right or left-handed forms which are mirror images but cannot be superimposed. That is about chirality. They are existing as a right or left-handed forms which are mirror images but cannot be superimposed. What my mean is, I don't know whether you are able to see my hand here because we are now in the thing. I will show you later on. That is, superimposing is like this. Okay, so when you do that, the thumb goes in the opposite direction. But when you say namaste, you are opposing. That is opposition. Whereas when you want to superimpose, then you have to put it on the dorsum. That means your left hand thumb will be pointing in one direction and right hand thumb will be pointing in front. So they cannot be superimposed correctly on the same side. This is called also enantiomers, which is substances of opposite shape. That is the meaning of enantiomers. And this form of stereoisomerism is dependent on one or more chiral centers. So a chiral center is a carbon atom with 4 groups attached. So you can see in this picture, this is the main carbon atom and it has got a COOH, an R, an amine NH2 and a hydrogen. So 4 groups are attached to the carbon atom. The other name for enantiomer is optical isomer, and it has the ability to rotate polarized light from one direction to another. So what other different nomenclatures are used to describe chiral substances? What are the other names that you can use to describe chiral substances? Because they are not described with only one name. Normally we see dextro or levo. That's common, all of you would have heard about it. Isn't it?
Sir, diastomer, isomeric blast.
Photomers.
So based on the optical activity, you can say it can be dextro, positive, if the plane of light is rotated to the right. And it can be levo or negative if the plane of light is rotated to the left. This is one classification or nomenclature. Based on the relation to the configuration of another molecule, that is neutraldehyde as D or L, not in use anymore. And the third is based on the sequence of attachment of atoms or groups to the central carbon. So this is the part you can see in this picture. The carbon is in central and the other things are attached like this. So they can form in the clockwise manning, which means it is R or rectus formation. And if the arrangement from largest to smallest group is in the anti-clockwise, it is called S or sinister. This picture will help you to remember this. For example, here, this is the central carbon atom, and the smallest to the largest goes in this direction. So 1, 2, 3 goes in the clockwise. That is just like your regular clock, 12 o'clock position, 3 o'clock position, 6 o'clock, 9 o'clock. It goes in the clockwise dot. Then it is called rectus or R form. Whereas if it comes in the anti-clockwise from one, this is of course this is the molecule which is not taken into account. Fourth, so this 1, 2, 3 comes in the reverse direction, and it is called the sinister or S. How do you write levobupivacaine enantiomer? Supposing they ask you to write the short form of levobupivacaine, how to write it? Answer is here already. You have seen the earlier one. Okay? So it can be written as S minus because it is a anti-clockwise rotation, and it is equal to the levo rotation. So both these things mean the same thing. S minus is the levo rotatory form. Mention the chemical properties of this drug. What type, what group of drug, what class of drug it belongs to?
Phencyclidine derivative, sir.
Phencyclidine derivative.
Phencyclidine derivative. Any other subcomponent or subdivision of phencyclidine? Phencyclidine is a large group. Does it come under any other subdivision or subclass of phencyclidine? It is a cyclohexanone derivative of phencyclidine. Okay, it's a cyclohexanone derivative of phencyclidine. That is a more detailed description. Of course, you will get the marks even if you say it's a phencyclidine derivative. Doesn't matter. But if you want to be the best in the answer, then you can give cyclohexanone. So it's a water-soluble compound. Chemical properties presented in concentrations of 10 milligram, 50 milligram, 100 milligram per ml with or without preservative, and a pH of 3.5 to 5.5. And it contains a rheostic mixture of two enantiomers, both dextro and levorotatory forms is there. How does it act? Ketamine. Very common question. What is described
NMDA
mechanism? NMDA
Cortical dissociation.
Cortical dissociation. So it is an NMDA receptor antagonist. That's the correct answer. And NMDA receptor is a L-glutamate receptor in the CNS with an excitatory action. Okay, this receptor causes excitation, and ketamine binds to a cation channel in the receptor to block this effect. That is how it is acting. Ketamine also acts on the opiate receptors by partial antagonism at mu and agonist action at K and delta receptors. That is how the analgesic component comes. It is not just by NMDA antagonism. It is also partial antagonist at mu, but agonist at kappa and delta receptors of the opiate receptors. So that is how the analgesic property comes for this. Enumerate the uses of ketamine in anesthesia.
Analgesia, neuraxial,
For induction,
induction,
For
anesthesia.
sedation.
I like that. Induction, it can be used for induction.
IV sedation,
IV sedation, very good.
Analgesia,
it can be used as standing dose in pediatrics.
Pediatric patients, very good.
For bronchodilation during intraoperative bronchospasm.
Bronchospasm, very good. Non-responsive to conventional methods, you can use that as a bronchodilator, very good. So can be
Adjuvant
used
to
as a
regional
detection
anesthesia.
agent for both for adults and children. Okay, that is the first one. used as an analgesic in field anesthesia, especially when you Odisha train disaster. Supposing somebody is in acute pain and you have to extricate them from the debris of the damaged coach, then you can administer small dose of ketamine and retrieve them without pain. So field anesthesia usage is very, very important and can cause bronchodilator even in refractory asthma, used for chronic treatment pain and for post-op analgesia, especially in patients who are opioid addicts. Okay, these patients do not normally respond to other agents, but they respond very well to ketamine. Opioid addict patients used as pseudoanalgesia during local or regional anesthesia. What are the routes of administration of ketamine? Very easy question.
Oral, IV, IM.
Intravenous, intramuscular.
One more route. Oral, IV, intravenous, intranasal. One more, I mean intranasal.
Intramuscular, sir.
IV, IM, oral, nasal, intrathecal, and epidural. Okay? So you can use preservative-free ketamine as an intrathecal for surgical analgesia as well as post-op pain relief. Okay, and they have been using it even for labor pain relief also. So IM, IV, oral, nasal, intrathecal, and epidural. Now what is shown here?
Sir, oxygen cylinder and nitrous oxide cylinder.
Nitrous oxide. There are different types, you know. It is not just oxygen cylinder and nitrous oxide.
E-type and
two F-type
Two
and two E-type cylinders of oxygen and nitrous oxide are shown. Okay. What are the parts of a cylinder?
Body, shoulder, and head.
So you have the body here, you have the shoulder painted white here, then this is the valve block, isn't it? So body, shoulder, neck, and valve block. Okay, these are the four parts. What is Wood's metal and where is it used and why?
Gas leak.
So, a temperature related something.
Huh?
Gas leak. To prevent
To prevent? To prevent what?
A protective mechanism in cylinder. Yeah,
Temperature related.
How is this valve fixed to this cylinder neck? You have this valve block which is a separate unit. Okay, so this will be screwed to the neck of the cylinder. So during that time, this Wood's metal is used there, so that when if there is a enormous increase in temperature, what will happen? These gases are filled with high pressure, and supposing there is a increase in temperature, what will happen? The cylinder can blow or get blast, isn't it? You'll have a and explosion of the cylinder will happen. So to prevent that, what they have done is they have used the Wood's metal in this position where you screw the valve portion into the neck of the cylinder, and this Wood's metal will
Metal is sensitive to temperature, it will melt and it will leak the gas.
wood.
It will leak the gas.
Are you discussing among yourself? When the valve portion is screwed to the neck of the cylinder, Wood's metal is used to seal any leaks. This metal will melt when the cylinder is exposed to intense heat and prevent explosion by allowing the gas to leak. So what you are using to seal a leak will allow melt and leak if there is a severe increase in the temperature, which may result in explosion of the cylinder. So the primary use of Wood's metal is to seal any leaks when this valve block is being screwed into the neck of the cylinder. But at the same time, it will act as a protective measure by melting when the temperature is very high to prevent the explosion of the gas by allowing some leak to happen. So it is a double-edged weapon. It is used for preventing leaks, but at the same time, if there is any chance of explosion, this will melt and prevent that explosion. What is shown in this picture?
बुल्स क्या बोलते हैं यार?
check valve.
Called check valve. Release valve. Okay, left bull nose valve.
Bull's
This
nose.
is called the bull nose valve, where you have to use. This is the outlet. This is the one which goes into the thing. This is where you can attach your pressure gauge or your delivery tube. This is the one which will be screwed into the neck of the cylinder. This is what I told you. This will be screwed here, and this is a hand wheel. This is a hand wheel type of outlet. Okay, so bull nose valve and hand wheel valve. These are the two things attached to usually the wad type. So this is the one. This is a larger cylinder which we use in the wad. Normally we don't use it in the machine. So there you will have these two types of valve outlets. So what is the advantage of this hand wheel valve? This is the hand wheel valve which you can just simply rotate and open the gas. What is the advantage? What do you
No need
require
of
for
oxygen key.
Huh?
Oxygen key is required to open the bull nose valve.
Does not require extra equipment like a wrench or the key to open that. Whereas for this you require a specific type of wrench or key which you have to put in and then rotate. Okay, all of you would have seen that being attached to the cylinders in the theater. What is seen in this?
Bottom first.
No idea?
Filling pressure in the cylinder, sir.
It is a portable cylinder with a built-in pressure regulator, mainly for home use. It's called integral valve. Okay, so this cylinder will show you the pressure. So this is a built-in pressure regulator is there with the outlet, and you can use this to open the cylinder. And when you are using it as a domiciliary measure, you know whether the cylinder has become empty or not. Whereas in this, you won't know. In this type of oxygen cylinder, if you are going to use it at home, you won't know what is the pressure inside, how much gas is left inside. So this is mainly for home use. What is shown here and where is it used? If you see carefully, you can get all the answers from this. You can see the name here is there. There is a number here.
Heliox.
It is a mixture of helium and oxygen.
Helium and
So
oxygen.
it's called heliox. Where is it used?
To relieve laryngospasm.
Upper airway obstruction. This is a cylinder containing 21%. This is, you can see 21 here. 21% oxygen and 79% helium mixture. And this is used in cases of upper airway obstruction to improve oxygenation. Okay, that is the use of that. So that finishes a full length of all the things. Already we have reached our time schedule.